Hi, I'm Dr. Tsay. We're going to be doing a case of a nose PDO thread using the new MiraQ LSCO thread. And so right here we have a really young, beautiful model, and she reached out to us and she said that she's would like a little improvement on her nose. So looking upon her anatomy, let's take a look at it together. We're looking at it's called the nasolabial angle, and that covers the philtrum up to the columella. So if you look at that angle, on a woman, ideally we want that angle to be about 95 and up, 95 to 100, maybe 105 degree maximum. So that's a really nice, beautiful nasolabial angle. For men, we want a little bit lower. We usually want 90 to 95. So if you look at the patient, that angle, you can kind of eyeball it. I don't carry around a protractor, but you can kind of eyeball that and tell that that's about 90 degrees. Okay, so she's right there. It's a beautiful nose. There's really nothing wrong with it, but she just wants it a little bit lifted. For some patients, they have a little bit more severe ptosis. You're going to have to lift even more. Typically, we put about 2 to 4 threads. Today, we'll probably start with 2 and we'll reassess. And with the LSCO thread, it's going to start going down the columella, and then it's going to come up, and then part of the thread does go up the dorsum of the bridge. And with the barbs, they anchor in the dorsum of the bridge, and that's what keeps the threads holding the entire nose bridge and tip up. It's really not primarily for building the bridge, although if you want to build the bridge, you can add more threads on the bridge later with MiraQ threads. I can show you which ones to use, but the LSCO thread is really unique because it traverses the columella and the bridge and gives more projection on the tip. If you look at the 90-degree angle, the traditional threads, you put them just on the dorsum of the bridge, and then you put the threads along the columella, and they're both cut, and there's really nothing there in the tip. So with LSCO, you've got threads traversing both the columella, the tip, and the dorsum of the nose, and it gives a really nice forward projection on the tip. Now, some contraindications if patient hasn't fully developed, young patient, that's a child, patient has had silicone, any implant to the nose, had previous rhinoplasty, they're probably contraindicated for this procedure. If they have any sort of cartilage from their ear or cartilage in their nose tip, they are not a good candidate for this procedure. So you really have to assess the patient. Also, lastly, if the patient does not have enough fat, so that's really, really important. If you look at the patient's nose and it's skin and cartilage, and that's all you have, you really don't want to put the threads because you're actually going to see the threads underneath the skin. Okay, so we're going to start off by doing a little lidocaine with epinephrine. Again, I use very, very small amount. I'm going to use the 30-gauge needle, numb, and then use a cannula to numb both the dorsum and the columella. We really like putting a little bit of a gauze here, especially if those that don't work with an assistant. I do have an assistant, but this really helps you because even though we're using lido with epinephrine in the nose, even after the porthole, there may be some bleeding, and having a little piece of gauze here is really nice because it's just going to catch some of the overflow and so it won't create such a mess. Let's go ahead and put some betadine before I start. For disinfecting purposes, you can disinfect in a variety of ways. My background is an emergency medicine doctor. We use a lot of betadine, but you can use chlorhexidine, microcin, and of course, we clean the skin off first with some alcohol before I even apply the betadine. And I'm going to start with some local anesthetic. First, I'm going to give a little blip to the tip of the nose, and just going to be a little tiny little mosquito bite right there, just a tiny, tiny bit. There you go. That's it. The cannula, 2270, please. Oh, is that okay? Very little, okay. Very, very small. Okay, before I start, this is just still part of the numbing process, but I just want to make a little porthole for the cannula. Okay, there you go, okay. And I'm going to use a 22 gauge, 70 millimeter cannula, and we're going to use this to numb both the dorsum and the columella. Okay, so here you go. A little squirt. I'm just checking right now. Does this, none of this should hurt right now, right? Right here? Is this any painful?
A little bit.
On the top of the bridge or on the tip?
On the top.
Top, okay. Okay, how about now? Any pain as I'm going back and forth?
Like a 2.
Okay, good. Okay. So now I'm going to numb the part that's called the columella. It's basically the spine that's right there down the middle of your nose. And then it'll be over. Breathe through your mouth. There you go. Almost done. Okay. Now I already put the anesthetic, so let me just check before I even start, just to make sure you're numb. Okay, I'm going to go back and forth with the cannula. Does that feel painful? No? Or very little, right? Very minimal, right? Okay, good.
Just a little slight pinch.
Okay, so yeah, so I used maybe 0.6 ml total, so that wasn't a whole lot. And again, we don't want to put too much tumescent solution because you want the barbs to have not too much water to so that the barbs are not swimming around in a lot of lidocaine solution. So here's the actual thread, the LSCO thread. So it's quite short actually. It's 105 millimeters, and it's got several markings on the cannula. So it actually gives you landmarks on where to stop, where to go to. I don't really use these anymore, the landmarks, but I kind of eyeball it, but that's nice that they have these on there. And so before we start, we're going to go down the columella first. The way this works is that because I'm right-handed, we're going to be going down the columella and then going up the bridge. And so for the first part, I'm going to be standing on her left, and on the second part of the procedure, I will be moving to stand on her right, and you'll see why in just a second. And so the first part, I'm going to go and just get the tip of the cannula inserted, and I want to lift up her tip. So this is very, very important. You want to lift the tip up to the position that you want it to be in an elevated position, and you're going to enter the skin bevel up first, and you're going to go basically the very first line. So you're going to go. There's one little line there, right where the sponge is holding the thread. You're going to go to the first line. Sometimes you feel a little pop. And then I'm in. Once I'm in, I'm going to turn the cannula and direct it down the columella. And then I'm going to go to the first line on that cannula that you see that's exposed. So I'm going to go down and insert, and you can feel the cannula sliding in between the fingers down the columella. And right now, I'm at that very first line. You can see it right there, very first line. And then I stop. In the next part of the procedure, I'm going to go to the other side of the bed. I'm going to lift the nose up and come out. The barb's there, so as I pull the cannula out, the thread's being deployed. And actually come outside with the cannula, and you see the thread is right there. And I'm going to leave about a centimeter and a half of a loop. I'm going to reinsert that cannula back in the hole that I made. And now that second part is I'm going to go up the bridge. And while I'm doing this, I'm still maintaining the lift. So, and I'm going to just go millimeter by millimeter. I'm just going to advance very, very slowly because I need to stay exactly in the midline. And again, I'm in the deep fatty layer, and I want to have full control and stay in the midline. So I'm just going millimeter by millimeter, and I want to go all the way until I get pretty much to the hub and where the tip of the cannula is at the past the radix. My fingers are guiding the cannula because I want to make sure that the cannula is not drifting to the left or right and stays exactly midline. So my fingers are right there guiding the cannula the entire way. And now the cannula is at the hub, and now I can remove the cannula. So I'm going to pinch the tip of the cannula and engage that thread, and I'm going to pull the cannula out. And then there's a little excess tip at the cannula, and I'm going to use some scissors and actually trim that. Sometimes you won't have this and sometimes you will, so it just depends on the patient's anatomy. So all you have to do, and this is really important, is to retract the nose back, and then you trim that thread as close to the skin as possible, and then you retract that nose back. And so when you touch the tip of the nose, there should be no threads protruding. So I'm going to start and reinsert the second one. Typically, again, 2 to 4 threads for the tip lift, to lift the columella, depending on their anatomy. Again, this patient has really good anatomy, so I may just do 2, but if they're very ptotic, you can go up to 4. And I'm going to start again, bevel facing up towards the ceiling. I'm going to lift her nose tip up. She's going to breathe through her mouth. I'm going to go to the very first line, and then I'm going to redirect the cannula down the columella and parallel to the columella, and just gradually advance the cannula to the very first line again. I'm right at the first line, and then I'm going to go to the other side, lift the nose up, come out, all the way out, create a little tiny loop, go back in the orifice, the porthole that I made, and then I'm going to advance this down the bridge of the nose, millimeter by millimeter. And I'm in the deep fatty layer of the nose. And so when I pull out, there's a little tail, and again, I'm going to trim that with a scissor. I'm going to retract the nose back and trim it. And this is really important because if you don't trim this far back enough, they can come back a couple of weeks or a month later and say they feel a thread popping out or coming out of the tip of their nose. And it's just an extra little minor issue that you have to deal with, but it's still an issue that you can easily resolve. So I'm going to actually pause and then reevaluate, but if you look at the side profile, you can actually see if you look at the side profile, you can actually see that even with those 2 threads that I inserted, that angle is very much lifted. It actually looks like she had rhinoplasty, but she didn't. This is completely non-surgical. And as a final measure, what I'm going to do is I'm going to take the remainder of the lidocaine that I used, and remember this porthole was created by an 18-gauge needle. I have seen these not healed properly if the patient is a smoker or the patient's rubbing their nose, sneezing, blowing their nose a lot. You can cause a little indentation here on the tip, but the way you minimize that is what I'm going to do is I'm going to use the lidocaine that I used to numb her, and I'm going to inject in the dermal plane. I'm going to inject dermally at 12, 9, 6, 3 o'clock. And so what this is going to do, and it's just a very small amount of injection, very small aliquot, and it's a dermal injection. This is going to help close up that wound. And then finally, as they're healing, you want to make sure you tell the patient to stay out of the sun. As they're healing, they should not be sunbathing or going out to the sun, because the sun can impede the healing process. It can actually cause hyperpigmentation of this little dot. And so you can definitely put sunscreen on it, cover it. I typically put a product called Strataderm. It's a silicone scar guard cream. Swiss technology, I cover that, and that is my Band-Aid. And of course, they can sunscreen it. And this lidocaine is going to close up that hole. It's still oozing a little bit, but that bleeding will stop eventually, and we'll put some Band-Aid on there. But I'm going to take off the bandage and we can take a look at the angle, and that's actually sufficient. Those 2 threads are sufficient. Now keep in mind the packaging of the threads, they come 2 threads per package, so that's why it's usually an even number. It's usually 2 threads or 4 threads. Yeah, if you look at that angle, yeah, that's at least 100-degree elevation of an angle there, and we can show the patient. Yeah, we're going to clean up a little bit more. Inject a little bit more lidocaine to stop the bleeding. The epi. So we'll have the patient take a look. There's a moment of truth, and take a look at your side profile. So, yeah, so that side profile is where the money shot is. That really is where you can tell the lifting. Not so much from the front, it's from the side. So post-care precautions, I usually tell people to not do anything that's going to cause them to smile excessively. No grinning from ear to ear, no sleeping on the face. Don't get a massage, because when you get a massage, you're going to face plant in that pillow and it's going to smush your nose. Generally, sunglasses are okay. Typically, the sunglass holders are on the sides of the bridge. They don't really interfere too much with the dorsum. And then also, you know, just, you know, also no blowing of the nose. Like, you know, if you've got a cold, you know, just lightly touch your nose, use a soft tissue. But if you're blowing your nose and you're pulling the nose down, you're going to pull that tip down as well. And then also, before I let the patient go, I always examine their oral mucosa, because where you're putting the thread, it's right adjacent to that upper lip philtrum area in the oral mucosa, and you really need to take a look at that. So I'm going to, first of all, ask the patient to make a monkey face. What that is they roll their tongue in the upper lip like a monkey, and ask if you feel any threads that are protruding through the oral mucosa. Do you feel any threads there? So she doesn't feel any threads, and I also inspect. So I will actually lift up her lip and inspect that area, move it back and forth, and I don't see any threads that are extruding through that oral mucosa, so we are safe. And that is a potential issue that if you're putting the thread too deep going down the column, you can pierce through and poke through the oral mucosa. If that happens, one, identify early. 2, you can just trim it. You don't have to remove the entire thread. You just trim it on the spot, and the problem is resolved. Okay. Antibiotics are plus or minus. There's no standard of care really. Some practices do offer antibiotics, some don't. It's really depending how clean you are and how you know, how aggressive you are in terms of offering antibiotics. I typically do, but there's a lot of practices that do not. But I do wear sterile gloves, and I do clean the skin very, very well. So that concludes. I hope you like the results, and also allow the patient to make them aware that the lift that they see, it does subside, it does settle by like a couple of degrees in the next couple of weeks. So it won't stay this high, but it will stay elevated. Just it won't be down to baseline for sure, but it will settle just very slightly, because right now it's swollen. Okay, thank you very much. I'll see you next time.